Thank you very much to the COLDA conference organizers for having TAC present at this wonderful event. I'd also like to thank Médecins du Monde, as some of the data in this presentation is derived from MapCrowd, which is a crowdsourcing platform co-developed with Médecins du Monde. So the objective of my presentation basically is to provide data on hepatitis C virus treatment restrictions and HCV treatment access barriers across Africa. And the goal is to inform government and community strategies on addressing these challenges to ensure access to HCV for all and achieve HCV elimination. The key takeaways from this presentation are that one, despite the voluntary licensing agreements concluded between Gilead and a number of generic manufacturers of pan-genotypic DAAs, these treatments are still not, access to these treatments is still not happening in a lot of African countries. So there have been significant delays in the registration of DAAs across countries, which also poses a barrier to access. Third, countries have a number of treatment access restrictions, which also pose a barrier. And fourth, key populations we think are key to eliminating HCV and must be prioritized by countries and national policies. There's no way we can achieve HCV elimination by excluding these groups. And of course, I invite you all to follow the Worth the Cure campaign, co-developed with a number of treatment access organizations. So follow it, share it, and join the campaign. So if you look at this WHO progress report on HIV, viral hepatitis, and STIs of 2021, you realize that at least at the global level, there is some good news. We've had reductions in global hepatitis burden. But when you narrow down to Africa, you'd realize that last year we had 210,000 new infections for HCV and 45,000 deaths from HCV. Now, despite the fact that these figures are significantly lower than hepatitis B infection, there are three key things we think countries should have at the back of their minds as they envision eliminating, achieving HCV or hepatitis elimination by 2030. So the first thing is that Sub-Saharan Africa has the highest burden of the difficult to treat HCV genotypes. So countries must work towards eliminating these HCV. Secondly, it is possible to cure HCV. And so while countries work on tackling hepatitis B or treating patients with hepatitis B, we think it is important to prioritize HCV cure for people who are co-infected with hepatitis B virus and HIV. And also, we think that given that HCV is the second leading cause of deaths for liver cancer and end-stage liver disease in Africa, it's important for countries, of course, to prioritize HCV elimination. Now, what we know today is that with less than $100 US, it's possible to have a one-course 12-week treatment, a 12-week treatment course for HCV. And so the treatment access barriers we're looking at are one, drug registration gaps. So we know that pharmaceutical companies, particularly that's in this case is Gilead and AbbVie, have been reluctant to register DAAs across African countries. Secondly, there have been limited resources in countries that have national regulatory authorities to review the regulatory dossiers once they are submitted for evaluation. Third, countries do not seem to have prioritized HCV elimination enough, and there's some sort of lack of political will in countries such that we do not have the exact quantities or numbers in terms of demand for HCVs, for HCV treatments, and this has been discouraging even for generic manufacturers to seek registration of their drugs in African countries. The second treatment barriers are the fact that countries have restrictions like fibrosis restrictions, which limit access to DAAs only to people with F3 or F1 fibrosis. There are sobriety restrictions, which basically require people to abstain from drugs or alcohol as a precondition for treatment access. And we have prescriber restrictions, which provide that only specialists can provide HCV treatment to patients. And we know that a good number of African countries have significant very limited numbers of general practitioners, talk less of specialists. And of course, these prescriber restrictions pose significant access barriers. And of course, we have other health system barriers like high out-of-pocket costs and high cost of transportation to healthcare facilities, among others. Now, if you look at this map on the registration of branded sofosbuvir-based DAAs under Gilead voluntary licensing countries, you realize that in this circle, we have over 40 countries wherein branded sofosbuvir-based DAAs are not registered. The African countries here are basically, in the African map, you have about 20 countries where some of these DAAs are registered. Now, the next map is about the registration of generic versions of sofosbuvir-based DAAs under the Gilead Voluntary Licensing Agreement. And here again, you realize that only in the countries in teal, so the countries in teal are basically countries in which DAAs are either not registered, or we were not able to come across data relating to the registration status of generic sofosbuvir-based DAAs in the countries. So you see that there's still a significant gap between the countries in gray where the drugs are registered and the countries in teal where these treatments are not registered. And this last slide with map is basically a comparison of treatment restrictions in across countries in Africa. Now, the first map relates to countries with fibrosis restrictions. The second is countries with sobriety restrictions, and then prescriber restrictions. So the teal color represents countries in which you have these restrictions. The yellowish color represents countries in which these restrictions do not exist. And the off-blood color represents countries in which we have no data as to whether these restrictions exist, or, you know, these treatment restrictions, either we did not come across data on whether there are such restrictions, or, you know, we are working with partners to investigate still whether these treatments are in place, these restrictions are in place in these countries. And of course, based on these findings, we have a number of recommendations to propose to countries. And the first, of course, is that governments need to strengthen an African regional regulatory authority to speed up registration of drugs generally. Governments need to work, of course, through procurement agencies to ensure that they pull the procurement of DAs together with the procurement of other drugs to benefit from lower prices. The African CDC and ministers of health need to review national hepatitis plans to remove treatment restrictions. Governments must make full use of the available treatment facilities like compulsory licensing. And of course, governments must also leverage HIV, reproductive and sexual health, and also harm reduction infrastructure and funding to include HCV in the Global Fund and PEPFAR country proposals. So this basically brings me to the end of my presentation. And of course, we're open to respond to any questions that people might have. And of course, we welcome new data from other organizations to complement this data that we've presented. Thank you very much.